Our next speaker is Michelle Neff, talking about sensorineural hearing loss.
Thank you. We're lucky we're going to get this on. That's it. Can't hear me, huh?
Just bear with me.
They run away. Okay, thank you. So yeah, my name is Michel. I work at Auckland Hospital and Starship Children's Hospital, and in the program it says I'm talking about sensorineural hearing loss, and I'll do this a little bit. I've got no conflict of interest. This is the auditory pathway, and normally when we deal with sensorineural hearing loss, and especially when you deal with sensorineural hearing loss, you'll be the auditory pathway is intact, so that you can place a hearing aid, or we can implant certain hearing aids to make the patient hear. Now, sometimes the hearing drops to levels where a hearing aid doesn't work anymore, and most of the pathway is still intact, and we can put a cochlear implant in. But what if the pathway is not intact beyond the cochlear nerve? And that's what my talk is about. So I want to talk about the first brainstem implant performed in New Zealand. And this is an auditory brainstem implant in a patient who did not have a tumor, and I can talk about that a bit later. So I'll be talking about, I'll give you a quick case presentation of this man, show you some surgical videos, and then the outcome for him, and then briefly discuss some of the implications of what we learned. So this gentleman is a 41-year-old man who lived in Rotorua, and he had a little sports injury and thought he should have that investigated, and had a knee arthroscopy in 2007. And what that is just there. You get put a little video into the knee and have a look around. But he's one of the few unfortunate ones where it got infected. So he got a septic arthritis. And unfortunately for him, again, this septic arthritis spread to the whole body. He became septicemic, developed endocarditis, so it affected the heart as well. And that was because he was infected by this bacteria here, Streptococcus viridans, which unfortunately was very resistant to most bacteria. And he was given gentamicin and vancomycin IV. And as most of you will be aware, this is a aminoglycoside. It's ototoxic, and it kills the little hair cells. So all that developed, what Peter talked about now, was destroyed. And that was happening for him. So initially he had a mild to moderate hearing loss after about a month, and then it progressed to profound levels at the age of 8 months. So normally, everything else, all the other investigations were normal. There was nothing else going on with them. And normally these patients do really well with a cochlear implant. And so he came forward for cochlear implantation pretty fast. He had a right cochlear implant in April 2008, then a left cochlear implant in June 2008, and a re-implant a year later in March 2009. Because every time the implant went in, he did really well. Excellent speech discrimination. In fact, after this first one, he was in the Rotorua News and was talking about how great it is and he could talk. But then the speech progressively got worse, and he ended up having non-auditory stimuli over a few months. So at the end of all this, in 2009, we were left with a situation where he could not hear and got absolutely no benefits from the cochlear implants. We had a non-user, essentially, functionally, he had non-functioning cochlear nerves. So this is the situation I want to talk about, because cochlear implant doesn't work. What can you do? And we started thinking about a brainstem implant. And a brainstem implant is a device that goes, and I'll show a bit more about that in a minute, goes into the foramen of Luschke, onto the cochlear nuclei. But what we didn't know for him is whether that would work, because we weren't sure whether the septicemia had just affected that or the rest of the pathway. And usually, we thought that if there was more neurological damage, then he should have more neurological signs. And he certainly didn't. He just had the hearing loss. No? An ABR, yeah. He didn't. But he only had integrity testing. Yeah. The ABI is placed onto the cochlear nucleus. This is the electrode here, and it is placed through the foramen of Luschke, which is an opening within the circulation of the brain fluids, the CSF. It goes onto the cochlear nucleus. This is the device. It looks just like a cochlear implant. Just the electrode is slightly different. You can see that rather than having a straight electrode, you've got this shoe with all the electrodes on there, plus some mesh around it, which keeps it in that foramen of Luschke. We finally got funding to send him, quite a few years later, if you look at the date, to send him to Fulda in Germany, because Professor Beer recently had a lot of good success with this implant and doing surgery on patients who didn't have tumors. And so we sent him there, sort of after thinking of doing it here or there. And unfortunately, at Switchern, there was absolutely no auditory stimuli, and as the stimulation level went up, he developed non-auditory stimuli again. And so we were back to square one. We did a CT scan. The electrode seemed to be in the right region, but we weren't absolutely sure about it. And there were lots of discussions. We rang sort of Melbourne. We rang, we talked to all the senior guys here, and a lot of negativity about brainstem implants because of sort of bad press and bad history. And now that he had failed his cochlear implants and his brainstem implant, I think there was a very strong feeling that he shouldn't go ahead with anything else. So what should we do? He is very motivated, and he decided that he should go ahead and have another implant. But we discussed with him, is this due to an implant failure? We didn't think so. Is this due to the auditory pathway not being affected quite badly, and there's never a chance for him to hear again? Or is it just a malposition where that electrode actually went into the foramen of Luschke, it all looked good at the time of surgery, and then fell out again? And we couldn't tell that from the CT scan, and there was no other scan that you could do. But he wanted more, so we made a decision to implant the other side. And this time we got Professor Beer to New Zealand after a lot of hoo-ha. He finally got here, and all this was funded by Medell, which were very generous. They wanted to make sure that they wanted to prove that their implant works. And surgery went ahead last year in March. And I'm just going to talk about that surgery now. So I don't know if you've seen, or some of you would have seen implant surgery, make a little cut behind the ear. But for the ABI surgery, you actually have to make quite a big cut to make it sort of open a big bony window up to get into the brain, retract the cerebellum, and have a look. So I've got a little video of that here. So it's already all opened up. So it's the same, similar view, and you're retracting the brain. And the first nerves that you see is the glossopharyngeal nerve, that's the auditory nerve just behind it. And the foramen of Luschke is here, so it goes in there, and it's already been dissected. There's a small testing electrode, which is a little bit small and slips in quite easily. And that was placed in different positions until we knew what the right position was, just stimulating it, measuring the whole time. And then once we were happy, the active electrode was placed. There you can see the mesh there. And then there was some more testing, making sure, sort of turning it around, moving it around until it's in the right position. and then it's just secured with that bit of surgery. So, and you can see that if the brain inflates again and you're unlucky, it can just slip out again. You know, you can't stitch it and you can't glue it in. It just needs to stay in that position. That's what might have happened on the other side. And then it just all gets closed up, and we did some intraoperative testing and all that was good. This is the ABI audiologist Jackie flew in from Hong Kong, and he spent quite a long time just intraoperatively measuring everything, making sure that everything was going well. And then we had some observers as well you might recognize. I've got Andrea and Helen there. Far left, that's Professor Beer from Fulda. Here's Chris Furno from Auckland. I'm around the corner there, hiding. And this is the post-operative CT scan. And this was quite interesting because this is the left side, this is the right side. And you can see the electrode going in here. This is the one that was sort of responding quite well intraoperatively. That's where it's sitting. This is the other electrode. You can see it's in a different spot. Okay, so what most likely happened is that after the initial surgery, with problems that he had, it just extruded and it never worked, and would have never worked. So this is what might have happened at switch on.
A small noise.
And this is what really happened.
It's very good sound.
So,
Yeah.
sound.
It's clear.
Clear sound.
Okay.
Which is good. We are stimulating at the.
It's quite high pitch.
Yeah, so we are stimulating at the middle, so which is a very good sign that.
So that was the first time. So he hadn't heard in sort of 6+ years, and that was the very first time. And it was just switched on, and immediately you could hear, and you could hear on all electrodes. And all this is pretty high tech and sort of very advanced. But could you see that piece of paper he's got in his hands? And that's the low tech part of it. So he had to sort of point. You know, it's loud, it's painful, it's not so good. But I'm sure they're going to advance on that. And this is at the end of the mapping.
How does that make your lip reading?
It's very good.
So you hardly need lip reading?
So,
Do you need lip reading still?
I think if it's noisy, I would need lip reading, but I think it's excellent.
I'll have to learn to talk again.
Where do I come from?
Where do you come from?
So,
This is amazing.
Great.
So that's a guy who hasn't heard for 6 years and who was absolutely hopeless lip reading. He could, you know, I would have to write everything for him. And this is on the day of switch on, he was able to do this. I've got the initial results after 2 months from switch on. His audiovisual is 100%. Audrey alone was 49 after 2 months. Word score was 21 with phoneme score 43%, which is pretty good after 2 months. And if you look at sort of results of ABIs over the years, there's an improvement, early improvement, quite a lot. So for 2 or 3 years is quite a significant improvement. But then there's still improvement for about 6 years, so he'll still get better. And he's gotten better, but I haven't got the latest results from, I think, March or April, when he had his follow-up, this year follow-up. I had a recent email from him, which is over a year from switch on, and he's now about to start his new job. He's still struggling to hear on the phone, but he's able to communicate, and this is his first job in 8 years. So in summary, this is the first reported case of reticochlear deafness due to aminoglycoside toxicity. Normally affects the hair cells. We're not absolutely sure what was going on with this nerve. We never took a biopsy of his nerve. Intraoperatively, the nerve looked normal, but it doesn't mean that it was functioning normally. It's the first brain stem implant in New Zealand, but we hope to do far more. And this is the pediatric part now. There was significant delays. You know, it took 6 years to get this organized. If you translate this into a child who might need a brainstem implant because there's no cochlear nerve, there's a hypoplastic nerve, or there's a dysplasia of the inner ear, we miss the boat. Okay, so kids need to implant it much quicker, and so we're working on trying to organize something where we can go through the Ministry of Health much quicker than we managed for him. I should acknowledge the Medal team, we're very good, and that's it. Thank you. Any questions? Initially, we got Professor Bear over to do that, rather than implanting the other side. The problem is that, you can do a lot of damage. There's always scarring, and, once you start pulling on structures inside the brain, you can damage other nerves, you can damage major blood vessels and cause more harm than good. And because it had failed, I thought, the best chance would be to just try the other side, give it one last good shot, and I think it just worked out for him. No, I think, most of the individuals are patients with neurofibromatosis. Those are patients who've got bilateral brain tumors that result in complete hearing loss, either due to surgery or to the tumor. And there are lots of them. I've got, just on my books, just sort of thinking quickly, I've got 4 people who would benefit from this, so I'm having to have a tumor removed. I've got a few children, children, they're rare, but we get the odd kid where you think, well, this would do well with the brainstem implant. So it's going to be rare, it's not going to be expensive for the government, but it's going to be, initially, there's going to be quite a lot of patients, and then it's sort of, once every couple of years, I think.
Do you think that the fact that the second one was a Medal and the first one, I believe, was a cochlear, had anything to do with the success?
They were both Medal.
Are they both Medal?
Mm-hmm.
Okay.
Sorry, this is almost a peripheral question, really. You seem to be putting his progressive central type hearing loss down to the aminoglycosides. Is there any suggestion it may have been sort of secondary to the septicemia instead? Yeah, absolutely. I mean, it's possible. The other thing which is very hard to determine in retrospect is whether he actually was vertiginous at the time when he had the hearing loss, which would suggest that it's more the inner ear. But apparently he wasn't, but we're not absolutely sure, and he can't recall. But I mean, that was the problem, that we had. Is if it's the septicemia, why would it just affect the, cochlear nerve and nothing else, And from some of the kids with meningitis who don't do so well, they actually have other neurological problems, processing problems, autism, and I would have expected a little bit more, but definitely, I mean, we think it's a bit more than just aminoglycoside, but you can't prove it.
Thanks, Michelle. I just wanted to say these sorts of things always make me teary, so thanks for making me want to cry whenever we see switch-ons. But my question was around implantation and brainstem for children and what happens, just looking at the size of that implant and positioning it and the fact that babies are still growing. What's the long-term prognosis with growth and position, etc.?
I assume it's the same as in cochlear implants. We implant kids when they're 6 months old now, and we don't assume that we have to change the implant, but sometimes the electrode can shift, and then you would notice that, and you just have to remap, and I guess it's the same for the brainstem implants. I've just been to the pediatric meeting in France, and they did talk about brainstem implants, and their youngest is, they would not recommend implantation before 1 year old, but the earlier the better. And they've got sort of quite a few years follow-ups now. I mean, you're looking at 6-7 years of brainstem implants for young children, nobody's reported that it's come out after a few years. I think it just sits there, and the redundant electrode just sort of accommodates, I think. No, it just pulls out. I think the question was, as the kid grows, does the electrode pull out? And if you have a redundant electrode just sort of curled up there, you hope that with growth it just stays where it's supposed to be. but sometimes it can just come out a little bit. Yeah. I think that's it. Thank you.